Topic of the lecture today is skin and soft tissue infections. Now, this comes under the headline of infectious diseases, which can occur because of any microorganism or it can occur because of any other substance that might lead to these consequences, and microorganism infect that place rather later on. So, in this topic, we're going to talk about what kind of skin manifestations and infections come through and what kind of soft tissue infections do we acquire. So before we head on into the skin infections, we have to know what's the anatomical relationships of skin are. In order to know what anatomical relationships of skin are, we have to see the basic structure of skin very thoroughly. Now, as you can see, this is a specimen of skin so that you might know that where all these structures, where all these epitheliums, epidermises, dermises, follicles, stratums are found. Once we know their location, and then we talk about their infections, then we talk about their pathological consequences. In your mind, you'll have the idea that what's the pathology that's going on behind this whole process, and what's the area that's being compromised, and what's right next to that area, and there's a chance of getting that infected and affected. So first of all, we have stratum corneum in our skin. That's the uppermost layer. Afterwards, we have dermal papilla. Next on, we have stratum germinatum. Next on, we have post-capillary venules. Now, these post-capillary venules are there to supply these stratums and these derms, these dermal papilla with the blood supply they need for their well-being. Next on, we have subcutaneous fat. Now, this subcutaneous fat varies from person to person. So, it can be more in size, it can be less in size. That depends upon the health status of the person that we're talking about. Next on, we have deep fascia. Then we have these veins. These venules take this blood away from here and get it into these veins. Now these veins, actually these are venules. These will form veins afterwards, and then they will go into the vena cavas and then eventually drain into the heart. Next on, we have this artery which comes from the heart, which supplies this whole system, which supplies this whole structure, supplies this whole tissue. Now, this is the crust of the skin. In most of the cases, in most of the infectious diseases related to skin, this crust is removed. The skin crust is removed in those diseases. So you have to know where the crust is. Whenever I'll say the crust of the skin is removed in this disease, you have to know that crust was present superficially. So it's rather visible that crust is removed. What about you have this idea in your mind that crust is somewhere right here? That won't be right. So you have to know the anatomical relationships of these structures in the skin in order to understand the better pathology of them. Next on, we have this hair follicle, which comes from all the way down. This is the hair follicle. This is hair follicle. Hair comes out of it. Next on, we have these vesicles on the skin. Further on, we have these eschar. I'm going to talk about what eschar is in the detailed slide. Next on, we have this bulla formation. Now, these vesicle, eschar, bulla, now these are the pathological manifestations. We're going to talk about all of them. For now, you have to just learn what the anatomical relationships of these pathologies will be. So you can see eschar is found on the skin. It's found on the epidermal layers. Then eschar stays the same way. Then bulla stays the same way. They're not going into the deep tissue. They're not going even into the stratum gravinatum. They are being contained in stratum corneum and dermal papilla. Next on, we have these subcutaneous glands. What do subcutaneous glands do? They produce a lot of sebum. What does sebum do? Sebum comes to your skin. It's protective in nature. It's oily in nature. Whenever you are sitting and it has been like 3 to 4 hours since you wash your face, and you go like this and you feel this oily musk of some presence on your skin, it's this sebum produced by these sebaceous glands. These are protective in nature, and they actually protect you from getting many kind of skin tumors. Next on, we have these lymphatic channels which will drain the lymph from here. In case of any infections coming in, or in case of any active infection, the lymph will be drained by these lymphatic channels. Underlying all of these things, underlie what? Muscles. Underneath them is the muscle. You can also say they're the protective barrier for the muscle, or you can say muscle is being supplied by these blood vessels and veins take the blood out of them, just like this skin mechanism. So, as we're talking about this skin and soft tissue infections, these soft tissue might also include the muscle, because muscles are in close proximity to the skin. If there's any kind of infection which infects and goes deep, it might reach to the muscle. It might cause myositis in some cases. Next on, we have this bone underneath, and this I just told you, muscle infection will lead to myositis. Next on, where the necrotizing fasciitis will be. Necrotizing fasciitis comes in the subcutaneous fat. It involves sebaceous glands. It involves all of these structures underneath the superficial layers, which involve bulla, ester, and vesicles. Next on, cellulitis is basically confined to the dermal layers. It is confined to the dermal layers. It affects the hair follicles. It affects and it reaches up to the folliculitis. It does involve sebaceous glands. It does involve subcutaneous fat in some cases. Next on, this pathology of erysipelas, we're going to talk about it. It's going to involve stratum corneum, stratum germinatum. So let's talk about this. First of all, let's talk about all of those infections, all of those pathologies which are associated with vesicles. We just talked about vesicle, that where vesicle is found, it's found on your superficial skin, it's found on your surface. So let me ask you, what vesicle is? What's the concept in your mind? Whenever I say the word vesicle, what comes in your mind? Vesicle is actually a space containing serous fluid or fluid on your skin. It's just a well-demarcated area, mostly it's less than 1 centimeter. It's mostly a well-demarcated area which contains fluid, and it involves the superficial areas of the skin. So which diseases involve the formation of vesicles? Let me tell you what kind of skin manifestations come when you are developing a disease, or when you have developed a disease, or when the infection is active, or when it's gone. There's 3 to 4 types. But among those 4 types, when we talk about kind of rash, we think of only 2 possibilities. Either it's maculopapular rash, or it's vesicular rash. So this point, keeping in your mind, maculopapular rash will be found in mumps, in measles, and in rubella. On the other hand, vesicular rash will be seen in all of these pathologies I'll tell you right now. So that's also a difference when you'll be learning derma and what kind of rash comes in with kind of pathology. So these are the infections associated with formation of vesicles. What infections are there? First of all, there's smallpox, which is caused by variola virus. Next on, we have chickenpox, which is caused by varicella zoster virus. Next on, we have shingles, which is also caused by varicella zoster virus. Next on, we have cold sores, which are caused by herpes simplex virus. Now, a little bit about all of them pathologies. Now, this smallpox is caused by variola virus. Now, smallpox was the epidemic in the last centuries, but it has been eradicated because there was no certain treatment for it. We just inoculated vaccinations for eradication of smallpox, and today the last case of the smallpox has been reported like a decade ago. Next on, we have chickenpox, which is caused by varicella zoster virus. Now, chickenpox, you still see chickenpox in some countries, some underdeveloped countries, in which varicella zoster virus will get to you, and it will lead to formation of vesicular rash. Now, you can see these are the vesicles, well demarcated, raised lesions, which are filled with fluid. Next on, we have shingles or herpes zoster virus, which is caused by varicella zoster virus. Now, this has the same pathology of chickenpox. It is also caused by the same organism. But what's interesting is that shingles are caused afterwards chickenpox. It happens in those cases in which the patient or the person who suffered from this chickenpox got better. There was no abnormality. There was nothing going on. He was totally fine. He recovered from chickenpox What happened afterwards? This organism, varicella zoster virus, was still present rather inactively inside your body. So whenever it goes active, it leads to the formation of shingles because antibodies against this pathology has been already produced. So that's why the people say you only get chickenpox once in your life. But that organism might lead to the formation of shingles. Next on we have cold sores which are caused by herpes simplex virus. These cold sores basically involve what? Your lips. These cold sores involve your lips, and their pathology is also lined with this whole category. Next on we have infections associated with vesicles. We have some more of them. First of all, we have herpetic whitlow, which is caused by herpes simplex virus. So cold sores were also produced by this virus, herpes simplex virus. This also leads to the formation of herpetic whitlow in the finger beds or in the fingernails of the patient. Next on we have herpetic or herpes gladiatorium. Now this is also caused by herpes simplex virus. Just like the other two pathology we just discussed. It manifests in your body and then it leads to the formation of herpes gladiatorum. Next on we have hand, foot and mouth disease. It is caused by Coxsackie virus A16. Now A16 is subspecies of Coxsackie virus, and this will lead to the formation of vesicles on three basic places or three basic surfaces which involve hand, foot and mouth. And what surface of hand and foot? This surface of hand and foot, right? So it is caused by Coxsackie virus. It will also lead to the formation of vesicles which will be filled with fluid, and afterward they're gone. It's entirely possible that they leave scars. Next on we have ORF, which is called by parapox virus. Now parapox virus will lead to the formation of ORF. As you can see, it also involves the distal areas of the body and it leads to the formation of vesicles. Now these are all the pathologies which involve the formation of vesicles, so that you get this idea whenever you listen to this, that a person got smallpox, a person got chickenpox, what kind of raised lesions will be there. Your mind should jump toward the conclusion that it's a vesicle formation will be there. That's why I'm telling you all of these pathologies which are related to the formation of vesicles. Now this is molluscum contagiosum, which is caused by molluscum contagiosum pox virus. Now it's also leading towards the formation of vesicles. Now these are the rare pathologies that we're discussing right now. These are not the major pathologies. We discussed the major pathologies in the last two slides. You will hear more about them. But you have to know that rickettsia pox is called by rickettsia acari, and it's also leading to the formation of vesicles inside your body, outside your body. Next on we have blistering distal dactylitis. Now it's also called by Staphylococcus aureus or Streptococcus pyogenes. This also leads to this inflammation. Now this is the only pathology that we're talking, and this leads to this kind of inflammation, this major kind of inflammation, and it's involving the whole digit, and it's also leading to the formation of vesicles. Now infections associated with bulla formation. Now we talked about the formation of what? Vesicles. We talked about all those infections which were remotely or directly related to the formation of vesicles. Now let's talk about the infections which are associated with bulla formation. Now what is bulla? You might be wondering, what is bulla? Bulla is actually a space or a sac which contains serous fluid. Bulla is a sac which contains serous fluid. As you can see, this is the formation of bulla. It's a sac which contains serous fluid. Now it is caused by either staphylococcal added skin syndrome like Staphylococcus aureus, or it can be happening because of necrotizing fasciitis, which is called by Streptococcus pyogenes and Clostridium species. We're going to talk about necrotizing fasciitis in detail. So bulla is the formation whenever, we just talked about, there's staphylococcal added infection. For example, there was a break in your skin and some organism like Staphylococcus aureus came in and it led to the formation of bulla, which is what? A sac containing serous fluid. And it can also be due to necrotizing fasciitis, which is caused by Streptococcus pyogenes and Clostridium species. So these are two basic reasons or two basic pathologies which are related to the formation of bulla, and these are the infections which are associated with the formation of bulla. Next on we have gas gangrene, which is caused by Clostridium species. We're going to talk about gas gangrene in detail. So it is also associated with the formation of bulla, and it is caused by Clostridium species, just like necrotizing fasciitis. Next on we have halophilic vibrio, which is caused by Vibrio vulnificus. Now this also leads to the formation of bulla. So next on we have these infections which involve or which are associated with crusted lesions. Now in vesicle there was no crusted lesion, there was no hard surface on the on this landmark of this pathology. Just like that, in bulla there was no crusted lesions whatsoever. But what are those infections which involve the formation of crusted lesions over that infected site? Now we look at the skin again. We look at the anatomical landmark of the skin, or that graph we talked about, or that diagram we talked about, so that we might get the idea that which areas get affected more and which areas and which infection will lead to the formation of crusted lesions. First of all, we talked about this. What is this? This is a crusted lesion of the skin. So nocardiosis will affect it. Cutaneous tuberculosis will affect it. Cutaneous leishmaniasis will affect it. Blastomycosis is one of the basic reasons that you get these crusted lesions on your body. Then we have coccidioidomycosis, histoplasmosis, sporotrichosis, ringworm infestation will lead to crusted lesions. Then we have Impetigo contagiosa. Next one we have bullous, Impetigo, or ecthyma. Now these are the infections which are associated with the formation of crusted lesion. In this bullous impetigo is not bulla. You don't have to confuse between bullous impetigo and bulla. These are very different pathologies, different manifestations. Next on, let's talk about folliculitis. Up till now, we talked about different kind of infections which we will look for whenever the word vesicle will come in. Different kind of infection we will look for whenever the word bulla come in. Different kind of infection we will look for whenever the word crusted lesions will come in. Like you have an exam and there's a question that a patient has dermatological manifestations, and there's this fluid-filled sac and it contains serous fluid. Your mind will directly jump to bullous formation or bulla formation. So that was for that purpose. Now let's talk about in detail what folliculitis is. Now this is a hair follicle. So folliculitis, meaning inflammation of the follicle, inflammation of the hair follicle. Now this can be due to what? It can be due to furunculosis. It can be due to hot tub folliculitis. Next, it can be due to swimmer's itch, and it can be due to acne vulgaris. Now, these areas which are demarcated or which are labeled here, now these areas are the areas which get affected. So even in a hair follicle, there are certain areas at which different pathologies will be born, at which different pathologies will be acting on, or different pathologies will be generated. Furunculosis occurs basically on the very superficial area of the hair follicle. On the other hand, hot tub folliculitis will be rather deep. Then swimmer's itch will come in. And then at the end we have acne vulgaris, which is involving basically what? Sebaceous glands. Because in acne vulgaris we have excessive production of sebaceous product or sebum we call. So when that is being produced and there's some kind of obstruction and that cannot go out, that will lead to the formation of acne vulgaris. Now you have thoroughly looked at what areas are being involved in these pathologies. Now look at these pathologies. First of all, we have furunculosis. Now what is furunculosis? Furunculosis is infection of the hair follicle basically. When hair follicle is involved, it will lead to this pathology. It can involve more and more hair follicles. It can go deep. It will involve more and more follicles. And sign and symptom of furunculosis is when you will touch the patient beyond the well demarcated line, they'll feel the pain because of the furunculosis. Next on, we have hot tub folliculitis. Now it's called hot tub folliculitis. Why? Because it occurs whenever you go for bath in a hot tub, and these organisms might lead to the formation of folliculitis by some kind of breakage in your skin, or in some cases it's not the breakage, they just get inside your hair follicles and lead to the formation of folliculitis, and that's why it's called hot tub folliculitis. Next on, we have swimmer's itch. Now, swimmer's itch, why it's called swimmer's itch? Actually, it's not because of any infection. It's actually an infestation. It's actually due to a parasite. Now, those parasites are present inside the water. There's no connection to them. There's no connection of that water to a person or that parasite to a person, but they are being injected or they are being secreted by these snails which are present inside your water. And whenever a person goes for a swim, those parasites are going to get attached to the body. Now, their host is not human. They are not attracted towards human. But if they get onto humans, they don't do much, but they will lead to the formation of the swimmer's itch. They will get inside your hair follicles and will lead to this formation, which you can see right here. That's why it's called swimmer's itch. It happens when you go for a swim in this kind of water. Then we have acne vulgaris. Now, acne vulgaris is caused basically in two groups. Basically, it happens in puberty, or if someone goes through this process of folliculitis. Now, what happens is that sebaceous glands are present with hair follicles. Now, those sebaceous glands are responsible for production of sebum. That sebum then travels back to the skin from the hair follicle. From down there, it travels to the skin and it lies the skin. It lies the superficial skin. Now, what happens is that due to any pathology or due to any reason, it leads to the blockage of sebum inside the sebaceous glands, and those hair follicles are filled with that sebaceous material or sebum, and when it cannot get out, it will lead to acne vulgaris. Now, what are those reasons which cause this pathology? This acne vulgaris is caused by basically what? It can be because of puberty. What happens in puberty? Androgens hit in, they cause more and more stimulation of these glands, and that might lead to this overproduction, might lead to acne vulgaris. Or it can be because of familial history. There's history of acne vulgaris inside the family, so that might lead to acne vulgaris. And next on, there are reasons that we don't know of. People just get it. They don't even have family history. They don't even have this kind of pathology that we talked about in folliculitis. So that's also one of the reasons people get acne vulgaris. Next on, we have myositis and myonecrosis. Now, the word myositis should tell you a lot of things. Myositis means, myo means muscle, and citis means inflammation. Inflammation of the muscles and necrosis of those muscles. Now, it can be caused by very deep infections, very deep infestations. So it can basically be due to what? A break in your skin. I'd say I'll bet 10% on that. But basically, it happens due to hematogenous spread of some organism. So what happens in myositis and myonecrosis is that it will lead to pyomyositis. Pyomyositis is pus formation inside the muscle and inflammation, which is caused by what organism? Staphylococcus aureus. Next on, we have streptococcal necrotizing myositis. Now, this is called by, as the name indicates, this is called by streptococcus. But which streptococcus? Streptococcus pyogenes. Streptococcus pyogenes will lead to the necrotizing myositis. Muscles will be necrotized in this condition. Next on, we have gas gangrene. Now, I told you we'll talk about gas gangrene in detail. So I'm going to tell you a background of gas gangrene in this slide. So what a gangrene is. Before we go on to gas gangrene, we have to know what a gangrene is. Gangrene is actually necrosis of tissue or destruction of normal tissue because of impeded blood supply. When it's not getting enough blood supply, it will lead to gangrene formation. When there's not enough blood supply or the blood supply has been impeded and that area goes into necrosis, now that is called gangrene. Now the gangrene is further subtypes. There's dry gangrene, there's wet gangrene, and then there's gas gangrene. And we are talking about gas gangrene here. So what can be gas gangrene due to? So gas gangrene is caused by those bacteria or those organisms which produce such gases and will lead to some kind of blockage of the blood supply. Now, it can't be that way that those bacteria will produce some gases and that will lead to blockage. It might be the other way around. There's some blockage, then that area is subjected to ischemia, that area is not getting enough blood supply, and then those bacteria came in and they produce those gases, and it will lead to the formation of gangrene was already being produced. Now it's being produced gas gangrene. What gases will be produced? Basically hydrogen. And this will lead to the formation of gas gangrene, and it is caused by what? Clostridium species. Next on we have non-clostridial myositis. Now this is the only type in which Clostridium is not involved. Not only type, but basically Clostridium is involved in myositis, so that's why it's called non-clostridial myositis. In this, what happens is that mixed aerobic and anaerobic organisms come in and they lead to the formation of myositis. They lead to the muscle inflammation and this pathology. Next on we have synergistic non-clostridial anaerobic myonecrosis. We talked about myositis of these organisms, aerobic and anaerobic. Now we're talking about the necrosis of mixed aerobic and anaerobic organisms that lead to this condition. That's why it's called synergistic, meaning mixed aerobes and anaerobes are coming in. Non-clostridial, we talked about Clostridium is not involved, myonecrosis. So these are the subtypes and types of myositis and myonecrosis and different conditions which are caused by different kind of organisms. So basic organisms which involve the skins, which involve the muscle, are Staphylococcus aureus, Streptococcus pyogenes, Clostridium species, mixed aerobic and anaerobic organism or bacteria. Next on we have necrotizing fasciitis. When necrotizing fasciitis manifests, what is necrotizing fasciitis basically? It is a progressive, life-threatening soft tissue infection with liquefactive necrosis. Now this definition might be hard for you to digest. It's actually a soft tissue infection which is life-threatening in nature because it involves liquefactive necrosis. Basically what it involves, let's talk about derma, let's talk about the infections we're talking about, let's talk about the skin which is involved. Basically it involves superficial fascia, then it goes to the deep fascia, and it might or might not involve the skin. So skin is either involved or not. It's not sure, it's not pet for skin to be involved in this pathology. So what happens is that in this kind of liquefactive necrosis, what's the pathology behind it? Or what the pathophysiology of liquefactive necrosis, you might say. There are multiple reasons for necrotizing fasciitis. First of them will be due to any surgery. If there was a surgery performed and there was a damage to certain place or certain tissue, and that led to hypoxia in that tissue, that will lead to necrotizing fasciitis. We're going to talk about how it will lead to that, but before that, let me tell you what are the reasons behind it. IM injections might be the cause, intramuscular injections are the cause. Next on, it has been seen the use of NSAIDs or non-steroidal anti-inflammatory drugs that we give to the patients can be the cause of necrotizing fasciitis whenever there's a varicella infection is going on, right? And these are the basic causes of necrotizing fasciitis. Now, it can also happen because of a systemic disease in which blood supply is compromised. So that can be due to any kind of immunosuppression that is going on inside your body or any other reason. So these are the 4 basic reasons that lead to its pathophysiology. Now what's its pathophysiology? The pathophysiology of necrotizing fasciitis lie that there's an entry of organism due to any reason. We talked about surgery. That might be the reason. There must be some break there, or the hematogenous spread happen, or whatever the reason is. That organisms, which we will discuss in this slide, those organisms made their way into what? Into those tissues which are being affected, into those tissues which are being affected. Affected how? Their blood supply is being compromised. So if their blood supply is being compromised, what will happen? They don't have enough oxygen. They will have a perfect environment for them to grow. So facultative organisms will just take upon it and start growing and start growing and start growing. When they are growing at such rapid speed, this will lead to involving more and more area of the skin. Now that area is compromised until we have this angiothrombotic organisms coming in. When the angiothrombotic organisms will come in, that will lead to necrotizing fasciitis. This even this term necrotizing fasciitis means fascia is being necrotized. Whether the skin is involved or not, it only depends upon different kind of cases. Now, which organisms were those we just talked about that they make their entry inside the wound or inside that system or inside that tissue which is being affected somehow? What are those organisms? We talked about streptococcus. Now, streptococcus is one of them. Streptococcal gangrene is formed. Now, this is a foot of streptococcal gangrene. Why gangrene is being formed? Because blood supply is being compromised. Afterwards, all the tissue will go into necrosis and the gangrene will form. Next on, we have Fournier's gangrene. Now, Fournier's gangrene is very specific in the formation. You will never see Fournier's gangrene anywhere inside your body except where? Except your perianal region, except your perineal region. Now, these are the only areas which are involved. You can see this is the depiction of that. This Fournier gangrene is being formed in the perineal region. Next on, we have staphylococcal necrotizing fasciitis that also happens because of this pathology, and it's happening because of staphylococcus. So basically, two organisms are being involved: streptococci and staphylococci, and that will lead to necrotizing fasciitis. Now you might wonder where the necrotizing fasciitis will be found. It's only found in either perineal region or the extremities, like in the legs, as you can see in the leg, in the foot, in the perineal region. It can also happen in the perianal region, right? So there are further two types of necrotizing fasciitis. I would like to tell you that first type is due to any kind of systemic pathology, basically like diabetes mellitus is one of them. If it's because of that pathology or if it's because of surgery, it's called type 1. In type 2, rather systemic manifestations come in, and that's because of other pathologies. But whenever you will hear the word of surgery, whenever you will hear the word of diabetes mellitus, what kind of necrotizing fasciitis that might cause? Type 1. Next on, we have ulcers with or without eschars. Now let's talk about these are the ulcers which lead to with or without eschar state. First of all, we have anthrax, which is Bacillus anthracis is the organism which called anthrax. Next on, we have ulceroglandular tularemia, which is caused by Francisella tularensis. So difficult names to pronounce. Next on, we have bubonic plague. Now, what is bubonic plague? Bubonic plague was one of those plagues which eradicated humans in the past, which led to deaths of many more. Now, this is called by Yersinia pestis. Now, it's also an infection. It's also a dermatological manifestations, and they lead to the formation of with or without eschars. We talked about what eschars are and where they are found. They're at the superficial level of the skin. Next on, we have Bullae ulcers, which are caused by Mycobacterium ulcerans. Next on, we have leprosy. We all know about leprosy, which is caused by Mycobacterium leprae. Next on, we have cutaneous tuberculosis, which is caused by Mycobacterium tuberculosis. Next on, we have chancroid, which is called by Haemophilus ducrei. And then we have this primary syphilis, which is called by Tinea pallidum. Now, this is all the conditions which lead to the formation of ulcers. Not to the formation of vesicles, not to the formation of any nodules, papules. They lead to the formation of ulcers. You can see all these ulcers being formed. Now, these ulcers are caused by this kind of pathology, and these organisms are involved, and they might involve the formation of eschar or they might not involve the formation of eschars. Next on, we have erysipelas, which is called by Streptococcus pyogenes. Now, there's a very minute difference between cellulitis and erysipelas. You won't be able to differentiate between them. Only differentiation point you will look for is involvement of the area, which area is being involved. So what this pathology involves is basically dermis layer of the skin and underlying fat. So that are being involved in this pathology. It also involves the lymphatics, which are superficial lymphatics. So this pathology involves the superficial lymphatics and the dermis layer of the skin. And the areas which get involved in the formation of this pathology are basically your peripheral areas, your distal areas like your toes, like your foot, and this might also include your face, in which your nose is the most has the most occurrence in the formation of this pathology. Next on we have cellulitis. Now cellulitis is an active acute reaction, active acute inflammation of the skin, which is caused by different organisms with different bacteria, which might get into your system by a breakage in your skin, which might have been due to any kind of surgery, any kind of trauma, or any kind of exposure. Those organisms get in, and they basically involves what layers? They involve basically the superficial layers, and then they might involve the lymphatics. And when the lymphatics are involved, they might lead to sepsis. When lymphatics are involved, they can go in your whole body. This infection can lead to sepsis and can also cause death in some cases. Now, cellulitis has been reported in basically those patients which are already suffering from other systemic diseases like diabetes mellitus. You will see the occurrence of cellulitis most in the patient who is suffering from uncontrolled diabetes mellitus. Now, what happens in cellulitis is that when you examine the patient which is suffering from cellulitis, you will see this redness, this inflammation, and it must be tender to touch. But what's the differentiating point is, if you touch the skin which is a little far from here, it will be not painful. So the tender area is localized. That painful area is localized in the cases of cellulitis, and it's a medical emergency. You have to treat it as soon as possible. In some cases, it goes to the surgical references and might lead to the amputations of the patient. Next on, we have papular and nodular lesions. Now, these are the diseases, or these are the pathologies which might lead to papular and nodular lesions. First of all, we have fish tank granuloma. It's called fish tank granuloma because it looks like it. It involves this pathology. It has this background. It is caused by Mycobacterium marinum. Next on, we have creeping eruptions, which are caused by Ancylostoma brasiliensis. Next on, we have dracunculitis, which is caused by what? Dracunculus medinensis. Next on, we have this serial dermatitis, which is caused by Schistosoma mansoni. Next on, we have this pathology of verruca vulgaris, which is caused by human papilloma virus. Next on, we have condylomata acuminata, which is caused by human papilloma virus too. Now, these are the perianal regions which are being involved. These are the digits which are being involved. These are the legs being involved. So this pathology can be anywhere, but basically it happens in the perianal regions. Basically, these nodular and papular regions erupt in your legs, and in some cases in your digits on your hands. So it basically involves the distal areas of the body, distal areas of the body. Next on, we have these papular and nodular lesions. You can see this onchocerciasis nodule. It is called by onchocerca volvulus. Next on, we have cutaneous myiasis, which is caused by Dermatobia hominis. Next on, it's verruca piranha, which is caused by Bartonella bacilloformis. Next on, we have cat scratch disease, which is supposed to be due to cat scratch, but it's not a pet rule that only the cat scratch might be the reason of this disease, and it is called by Bartonella hansella. Next on, we have lepromatous leprosy, which is caused by Mycobacterium leprae. Next on, we have secondary syphilis, which is caused by Treponema pallidum. Next on, we have tertiary syphilis, which is caused by Treponema pallidum too. So all of these pathologies, all of these infections are leading to this kind of skin lesions, papular and nodular lesions. So up till now, we have talked about vesicular lesion, we talked about maculopapular lesions, we talked about the ulcer formation, we talked about the crust formation on these structures. So these are the pathologies you have to remember, you have to associate with these headings. Whenever this word comes in, like secondary syphilis involves which kind of skin manifestation? It will involve papular and nodular lesions on the skin. So that's how it's important. That's why it's important to learn that which pathologies are associated with papular and nodular lesions, which pathologies are involved with vesicles being formed, which pathologies are involved in maculopapular rash, which pathologies involve the crusted lesions over them. So all of these pathologies are very important. You have to get your grab on it. Next on, we have talked about all of these diseases which involve the skin and soft tissue. So let's talk about the diagnosis. How will we diagnose the patient, that what pathology is that patient suffering from? So first of all, we'll talk about the travel history. But before travel history, what we'll talk about? We'll talk about the personal history. What's your name? Where have you been? Okay, what's the problem you have presented to us with? That will tell you the problem, that I have this inflammation of the skin which is right here and it's tender to touch and it's red and I'm having these bouts of fever, and your mind will start going to what? Cellulitis. You'll see the skin, it's red, swollen, it's inflamed, and then you will start to touch it where it hurts. Then you will move further along and then you will touch and there will be no hurting, there will be no pain. So you will know it's tender to touch, it's warm, it's red, it's the pain is localized, and patient having fever, maybe systemic involvement is already there. So this is how the history will go. You'll talk more about the presenting complaint, then you'll go for the personal history. Are you suffering from diabetes somehow? So diabetes is also one reason or predisposing factor for the formation of cellulitis. So that's how you will ask the presence of diabetes, or the patient is suffering from diabetes before or not. Then you'll talk about the immunosuppression, because these pathologies, all of these skin manifestations or these soft tissue involvements come basically in those patients which are immunosuppressed or taking any kind of immunosuppressants. You will talk about all of this. If they're taking immunosuppressants, you have to take them off the immunosuppressants. You have to treat them if they are immunocompromised already. If they are suffering from already a very severe systemic disease like diabetes mellitus, you will treat accordingly. So first of all, we'll talk about all of that history. Then you will talk about the travel history. You will talk about what places you have been. Have you been to this place? Have you been to this place? Why? Because most of these infections happened because of a breakage in your skin. When you were in a travel environment, were you subjected to any kind of trauma? Were you subjected to any kind of like a pool of water in which you went for swimming? That why it's important? Swimmer's rash. We talked about that. So these histories are very important. You have to ask that patient everything. Then you're gonna have to go to the lifestyle. What kind of lifestyle do you lead? What do you do? What do you do for living? What do you do afterwards? What places you go to afterwards? Then you have this animal exposure for these ticks and mites, and then different kind of pathologies. We talked about some parasites get the entry inside of your fruncles, and that might lead to this pathology. Next on, we have this bite history, where you bitten by any kind of dog, because what will that do? That will do a breach in your skin, that will also contaminate your skin, and it also opens up a portal of different kind of organisms that can get entry inside your system very easily through that area, very easily through that skin. Next time we'll talk about the age, because age is a very important factor. Like in acne vulgaris, it basically happens in what age? In adolescent. And other basic diseases which like cellulitis, it occurs later in the ages, because of diabetes mellitus is the major predisposing factor. So we don't see cellulitis happening in 8-year-old. It might happen. It's not like it's a hard and fast rule that it won't happen, but age is a big matter. Next, I'm going to talk about underlying disease status. I talked about that. We're going to talk about, is that patient suffering from diabetes mellitus? Is that patient suffering from any kind of immunosuppressant disease or immunodepressed disease? So moving on, we have diagnosis regarding tissue and soft tissue radiography. First, we went for history of the patient. We went into detailed history. We talked about all of his personal history. We talked about underlying diseases. We talked about the travel history. We talked about the lifestyle he leads. Now we have narrowed down our diagnosis. Next, we go on for soft tissue radiology. If you see any involvement of cellulitis, or you have to confirm that whether that patient is suffering from cellulitis or other kind of pathology, You have to go for soft tissue radiology. That will tell you a lot, that whether the muscles are being involved, whether the lymphatics are being involved, whether the soft tissue is being involved. Further on, you will go for physical appearance and location of the lesion. Now, you can go to radiology afterwards. There's, you can say, preference for every clinical practitioner, that whether that person or whether the doctor goes for radiological manifestations first and then physical appearances. But for me, it's first physical appearance and location of the lesion, and then radiological manifestations. So you'll see physical appearance of these lesions and location of these lesions. We talked about multiple pathologies that involve only genitalia, that involve only perianal region, that only involve feet. We talked about some pathology which involve your nose. We talked about some pathologies which involve your chest. So location of the lesion matters a lot in narrowing down more of the differentials. So next on, after looking at the physical appearance, after noting which area is being involved, and after going through radiological manifestations, what you do, you go for punch biopsy. If it's not being healed, you go for punch biopsy. This is the punch tool. You punch it, you take the sample out of it, and then you do what? After tissue sample is being taken, after tissue sample has been taken, you go and confirm your diagnosis, and then you start your treatment. But in some cases, you go for open surgical inspection and debridement. If the patient is already in sepsis and patient is going through a lot, you won't go for punch biopsy. If the more and more areas being involved, you won't go for punch biopsy. Like, this is the patient that presents to you. Now this is the presentation of that patient. What will you do? Punch biopsy? No, you will definitely go for open surgical inspection. You will openly inspect them. You will debride them. And then what happens? You'll totally, even the peripheral areas are being debrided in these cases because of a risk, because of a risk of them, those areas being involved laterwards. So you inspect them, you debride all those areas, you clean them. Then afterwards, what happens? Patient get better, and you get your diagnosis too. You even go for the medical treatment afterwards. So you start from open surgical inspection, you go for the debridement, and then you go for antibiotics or any kind of other covers which are required for that kind of pathology. Treatment. Let's talk about animal bite. First of all, if it was animal bite and that's going to cause some kind of skin manifestation and problems, what do? Prophylaxis or early infection. For example, a dog bit you. What do? You go to a doctor, you take these kind of treatments that I don't get, if it was not a rabid dog. If it was a rabid dog, you'll go for that treatment before going for any skin pathologies. You won't be worrying about skin pathologies or skin treatments, but you will go for your own treatment if a rabid dog bites you. But if it was not rabid, it was just a dog who was not rabid and it bit you or just scratched you, what will you go for? First of all, it's prophylaxis. You go for doxycycline, which is 100 milligram per oral BD. BD meaning in the morning and in the night. Like after 12 hours, for some days you take doxycycline. Now this is prophylaxis so that you don't get any kind of infection. But what if you do? Infection has already been established. You didn't go to the doctor. You were busy in treating the rabid dog bite and you didn't think about your skin manifestations. So what will happen afterwards? You will take clindamycin between 600 to 900 milligram depending upon your weight, and it will be taken IV and it will be given 8 hourly. Plus, ciprofloxacin is given as a cover, an antibacterial cover, which is given in 400 milligram IV every 12 hourly. Or you can go for cefoxitin, which is 2 gram IV, 6 hourly. Now these are the manifestations, these are the set marks for what you'll go through if you develop this kind of infection. Next on, we have treatment of bacillary angiomatosis, primary treatment and alternative treatment. First of all, primary treatment is erythromycin 500 milligram per oral, QIG meaning 4 times a day, QID meaning every 6 hours you have to take this medicine. And if there's any kind of alternative treatment, if someone is some kind of allergic to erythromycin or has developed resistance to erythromycin, what do you give? You give doxycycline, which is 100 milligram per oral BD, which is given in 2 doses between 12 hours. Next on, you have treatment of herpes simplex virus. Now, there's no proper treatment of herpes simplex virus. There's no proper treatment of virus. You observe and you treat the patient accordingly of those symptoms. It's not like there's a pet treatment like antibacterials. You have a pet treatment against different organisms, but in the cases of viruses, you have antivirals, yes, but they're not that potent. So basic modality that you have to use is time and observe it and treat the symptoms. But in herpes simplex, primary treatment is acyclovir, which is antiviral drug, 400 milligram per oral TID for 10 days. TID meaning 3 times a day for 10 days. Next on, we have alternative treatment as famiciclovir, which is 200 milligram per oral TID, or valacyclovir, 1000 milligram per oral OD. So these are the treatment modalities for herpes simplex virus. So you give antiviral drugs. Then you have herpes zoster. Now it's also a virus. You give acyclovir 100 milligram per oral, or you give famiciclovir 500 milligram TID, which is 3 times a day, or valacyclovir 1000 milligram per oral OG. Next on, you have treatment of cellulitis. Primary treatment is nephicillin or oxacillin, which is antibiotic, and alternative treatment is cefazolin or ampicillin and salbectam. Now, cefazolin is given when patient is resistant to ampicillin or is allergic. Many patients you will see they're allergic to ampicillin. So this is the basic modality of the treatment, or you can go for erythromycin, or you can go for clindamycin. You have all these antibiotics. What will determine which kind of antibiotic you'll go for? The cultures will determine that. The cultures will tell you what kind of antibiotic will be suitable, what kind of antibiotic is going to be sensitive to these organisms which are causing cellulitis. Next on, we have MRSA infection, which is methicillin resistant Staphylococcus aureus infection. Now, it's a very dangerous infection. We all know about that MRSA, whenever the MRSA is there, there's very difficult approach to the treatment. But what happens if it has been infected by methicillin resistant Staphylococcus aureus? What will you go for? First of all, you go for vancomycin 1 gram IV every 12 hourly. Or you can go for linezolid 600 milligram IV 12 hourly. Next on, we have treatment of necrotizing fasciitis. In some cases, you can also say the necrosed area might be removed, might be amputated, but in some cases it's not. So it depends upon the severity of the condition, depends upon the severity of the patient. So the medical treatment for necrotizing fasciitis is clindamycin plus penicillin G, and then we have clindamycin plus cephalosporin. Next on, we have the treatment of gas gangrene. We talked about gas gangrene. The treatment of gas gangrene is same as this. It's clindamycin and penicillin G, or clindamycin or cefoxitin. So we talked about all these soft tissue and skin infections. We talked about how those lesions will be presented to you, what lesions will be found in what pathology, like vesicles will be found in these 8 pathologies, nodules and papules will be found in these pathologies, maculopapular rash will be found in these pathologies, and crusted lesions will be found in these certain pathologies. You have to remember them in order to perform well, in order to maintain a concept that, okay, if bullous or bullae is being formed, so this might be one of these 4 or 5 pathologies. It will help you even in narrowing down your differentials. So that's all for today. Thank you for watching sqadia.com.